G-Echo session. We are very excited to have Simon Veenstra, who's a recently qualified subspecialty gastroenterologist, who's going to give us an approach to dysphagia. And we just like to say thank you to G-Echo. It's hosted by the Gastro Foundation in association with Project Echo and the University of New Mexico. And we know that the G-Echo Fellows runs every second Monday at 6 o'clock. And we'll keep the chat open for questions. So if anybody has any questions, please put it in the chat. Simon's going to give us a nice overview of dysphagia, and then we thought it'd be interesting this week to actually go through some cases. Some are a little bit more standard, some are a little bit more abstract, and we can maybe open the chat after each case and just discuss if there's any questions along the way and try and keep it somewhat interactive. I'm going to hand over to Simon now. Just unmute yourself, Simon, and then you can share your screen.
Cool. Thanks, Matt. Thanks, Cheryl, and thanks to the G-Echo platform. Can everyone hear me?
We can hear you.
Alrighty. Sorry. Let me just get onto the right. Alrighty. Okay, so you should be able to see my screen. Is that correct?
Looks good.
Alrighty. Cool. Yeah. So thanks, Matt. So as Matt has pointed out, the aim of this talk is really just to give some broad strokes and an approach to dysphagia. It's an incredibly broad topic, and it's quite difficult actually to summarize because of all the there's a multitude of causes, and it's obviously quite difficult to summarize and go through each one of those. But so we're going to just sort of paint a broad picture and then go through some cases which hopefully will be a little bit more interesting. So the UEG brought out some guidelines recently towards the end of last year, looking at dysphagia and looking at dysphagia and motility disorders. And I mean, I think we're all familiar with this definition of dysphagia, that it's a difficulty in swallowing. It's generally sensed retroexternally, and it can be caused by a number of things, but broadly anatomical, mechanical, functional abnormalities. I think it's important just from a demographic perspective and sort of epidemiological perspective to say that dysphagia is the incidence is increasing, particularly in younger cases where GORD and EOE are becoming more prominent, but particularly in elderly population, dysphagia becomes much more prominent in those patients where neurological conditions are found more commonly. Additionally, there's quite a significant impact on quality of life. And so it's something that really does need to be sort of diagnosed promptly if one can. And there's also a significant economic burden as well, with longer hospital stays and financial cost as well. So all things that need to be taken into account when one considers dysphagia in a patient. When it comes to what patients may report, there's obviously various symptoms that they may describe or explain, and history is really critical in teasing out what the patient is implying when they say they're having difficulty swallowing. Painful swallowing, obviously we know that as a dysphagia. Globus sensation is that feeling of a lump in the throat that persists even when not eating or in the act of swallowing. And then there's associated symptoms as well, like chest pain, heartburn, regurgitation. And so teasing out sort of all the details related to that are all very useful in pointing towards potential underlying etiologies. Musa gave an excellent presentation 2 weeks ago on the anatomy and physiology of the foregut. And so I'm not going to repeat much of that here, but just to say that obviously the upper portion of the swallowing apparatus is predominantly striated muscle and under voluntary control. Um, the lower portion is smooth muscle and involuntary, and then there's this mixture of striated and smooth muscle in the middle portion with considerable overlap. And with regards to the innervation, there's obviously central and enteric components, and understanding this entire complex is important as in when any one of these components fails, dysphagia may arise. So it is important to understand the anatomy, to understand the physiology. Um, Again, I think Moaz discussed the phases of swallowing 2 weeks ago, but again, just very briefly, swallowing can be thought of in three separate phases, namely the oral, the oropharyngeal, and the esophageal phase. Oral really is a preparatory sort of phase where the food bolus is lubricated and broken down in preparation of swallowing process. And then oropharyngeal is that process of swallow initiation. It's under involuntary control, and a lot of the airway protection reflexes occur in this phase. And then esophageal is the last phase, which the transit phase of the bolus down into the stomach with due to peristalsis, and that usually takes a couple of seconds. So, as I've mentioned, when one considers dysphagia, history is really the critical component. One wants to know things about when the dysphagia started, how long it's been happening, whether it's progressing, whether it's intermittent. Does it occur early on in the swallowing cycle? May point towards an oropharyngeal cause versus later, or a feeling of getting stuck in the esophagus. That often is a one needs to be a little bit careful, as patients may point towards a certain area, but because of the overlap in nerves, the precise location is often unreliable. Other things that one would want to tease out was whether it's dysphagia to solids only or liquids as well. Most sort of diagnostic algorithms break this down, as we'll see in the following slide, into solids or solids and liquids. Some suggesting that when it's to both, that it's predominantly a motility issue versus a structural or mechanical issue. And then whether there are any associated symptoms like drooling, coughing, which may point towards an oropharyngeal cause, or that the patient may be aspirating. And then obviously some red flag signs like weight loss and aspiration, which increases obviously your risk of mortality and complications. So the schematic is taken from Schlesinger, and as I've mentioned, it breaks your sort of algorithm into an oropharyngeal cause and esophageal cause, and then whether the dysphagia is to solids or solids and liquids. The character is also important, as I've mentioned, progressive or intermittent, and all of these point towards underlying or potential underlying etiologies. I don't think there's any hard and fast rule, but they are good indicators and may decide on how you would want to investigate these patients further. Excuse me. This is an incredibly busy slide, and I'm not going to go through everything, but I think it's just to point out that there are 1,001 causes of dysphagia. It's important to have, I think, an idea of some of the broader sort of buckets that cause dysphagia. As I've mentioned in the beginning, neurological conditions, particularly amongst the elderly, is an important etiology. But there are other causes as well, like rheumatological, endocrine, infectious causes, and then obviously structural, mechanical, and malignancies are things that we always want to rule out. So what sort of things do we have in our at our disposal to help delineate the underlying cause. So the majority of patients are obviously going to get an upper endoscopy, um, particularly if one suspects an esophageal cause. And I think it's important to point out here that even when the endoscopic picture is normal, one should always do biopsies to rule out eosinophilic esophagitis, and there's um, a protocol for that with both distal and mid esophageal biopsies to help with that. Uh, the other tests that are useful are your barium swallows, which is generally available in most facilities. And there's various iterations of that. There's your standard barium swallow, timed barium swallow, where one repeats the radiographs at 2 minutes and 5 minutes, and one can measure the column of contrast that remains in the esophagus. And then your video fluoroscopic swallow study, which is done with the help of the speech therapist, is very useful, particularly when it comes to oropharyngeal dysphagia. Speech therapist obviously is one of the key members of the multidisciplinary team when it comes to managing these patients. So a very useful study there as well. When it comes to your motility issues, this is where high resolution manometry really comes to the fore. It's the gold standard for diagnosing motility abnormalities within the esophagus. And then there are other adjuncts or nice to have, but are not necessarily available in South Africa. The EndoFlip, which is a functional luminal imaging probe, looks at distension or distensibility of lumens essentially, and helps provides a bit more information on what's happening within the lumen, within sphincters. However, this is not readily available in South Africa, or I don't think it's available at all, although it does seem to be coming or gaining traction overseas. And then pharyngeal manometry is also a nice test to do when one is concerned about a motility issue higher up, something like a cricopharyngeal bar. And this can be done with your standard high resolution manometry equipment by pulling up the catheter slightly to incorporate the oropharynx. But it's not done standardly. These algorithms are taken from the UEG, those UEG guidelines that I mentioned earlier, and essentially reiterates what I've mentioned already. So with patients with esophageal dysphagia, your initial test is going to be upper endoscopy with biopsies, again, emphasizing that. And then your next course of action would be related to whatever you find there. If it's a normal endoscopy, or not necessarily normal, but if there's concern for a motility or disorder, one would then go on to your high resolution manometry. And if that is normal as well, so no abnormality identified, one may consider adjunctive tests. If GORD is or hypersensitivity, reflex hypersensitivity is a concern, then your pH studies would be important to do. And if all of these are normal, then one considers functional esophageal conditions. Likewise, with oropharyngeal dysphagia, your first test of choice is going to be a clinical swallow evaluation, and then likely a video fluoroscopic swallow study with a speech therapist to identify abnormalities in that phase of swallowing. One may incorporate other specialists like neurologists or your ear, nose, and throat specialists. One would then also potentially go on to endoscopy if necessary, particularly if there's structural causes that you are concerned about in the upper esophagus or oropharynx. Cross-sectional imaging may also be useful. And again, if all of this is normal, one would then consider functional dysphagia. I'm I've put this in, but obviously management is is broad. There's not a specific management strategy for dysphagia because there's so many different etiologies. But just to say that for various sort of broad buckets like functional dysphagia, we have things like neuromodulators and your antidepressants to help with that. There's some evidence for alternative therapies, psychological therapies like cognitive behavioral therapy, um, and breathing exercises, etc. Um, but yeah, that would broadly cover those, the sort of functional dysphagias. Obviously, if there's specific structural causes, one would treat that accordingly, depending on what you find. And then with your motility disorders, there's again a host of potential options depending on what your underlying etiology is. So, and broadly speaking, one could break that into pharmacologic, endoscopic, and surgical. But I'm not going to get into too much detail related to that. Um, Likewise, with oropharyngeal dysphagia, um, if one is considering if it's an underlying anatomic condition, one might consider endoscopic or surgical treatment, depending on what the underlying cause is. For instance, myotomies for diverticulum. Um, um, yeah, it obviously will just depends on on the patient, on the underlying cause, and what one would consider the best way forward for that patient. Um, and then with neurological conditions, obviously treating the underlying disease, uh, and your rehab team really comes to the fore here in terms of strengthening respiratory muscles, swallowing techniques, and modulating food. For instance, your dietitian to uh, yeah, modulate the food to optimize nutrition and minimize aspiration risk. Um, so yeah, so essentially, this is the a very broad overview of dysphagia. As I've mentioned, there's a number of causes, and management and investigation and management depends on how you on the underlying cause and etiology. Um, and so, what we're going to do now is go through just some cases, and then I think this would be a bit more interesting and useful. So the first few cases we're going to show don't really have much in the way of patient history, but from an endoscopic perspective, let me just see if it's going to work. Yeah, so the first few cases are just some esophageal cancers. So we can see obviously going down into the mid-esophagus, and there's this nodular lesion. It's not completely obstructive, but this is probably a local to locally advanced esophageal cancer, and one would obviously biopsy that, and that would go into MDT and um, and would treat accordingly. Contrasted to this case, is this the right one? Was this the same one? Sorry. Here we go. All right, so this is more advanced cancer. One can see the fibrosis, and from a luminal perspective, there's the diameter has reduced quite a lot, and on a contrast fluoroscopic um, picture, you can see a nice apple core lesion there with shouldering. Um, so yeah, it's a more advanced cancer, and obviously you might treat that. You're going to treat that differently compared to the first one, depending on whether this patient is for palliation or for curative. Um, uh, yeah, on what you intend to do. Sorry. Alrighty. So mentioned,
Simon, can I
yes.
just chip in there before we move on to EOE?
Mm,
Obviously, the videos are quite straightforward. I think anybody who's on this webinar today, that I assume you all do some scopes or have seen endoscopy. I think this is the main reason why we do scopes and why I think scopes are the number one investigation we should do for patients with dysphagia. Some of our data that we're about to publish shows that at Skia, if the patient has dysphagia, even if it's one of the indications for the first scope they have here, so if you've ticked five different things and one of them is dysphagia, we looked at that and almost 20% of patients will have a cancer on their first endoscopy here. So you get an amazing hit rate from one symptom. So that I think this just highlights the importance of dysphagia. And I think most people that are on this chat live in what we call the African esophageal cancer corridor, which spreads on the southeast coast of Africa from here, from South Africa, all the way up to Kenya, Tanzania, etc. And we have the highest rate of esophageal cancer in the world. Malawi ranks number one in the world, which I don't know if everybody knows that. But six of the top 10 countries in the world with the highest esophageal cancer rates are all here in Southeast Africa. So we are a real hotspot, very much overlooked. So I think dysphagia is such an important symptom that we should pick up in these patients. That's why this talk is actually so very important. And we should never, ever deny the patient that chance. I know endoscopy is not readily available everywhere, but it's really a good reason to refer a patient for a scope because we pick these cancers up a lot. And I think in other countries, even more so. Thanks, Simon.
well, thanks, Matt. So, as I mentioned earlier, this is also um, another cause and something that is probably increasing in incidence, possibly because of increased awareness. But EOE obviously has pathonom sort of classical features. Um, so here, is it playing nicely? Yeah. So here we can see as we go down the esophagus, we see rings, and some people describe it as a sort of a crepe paper type of morphology. So very sort of thin, crinkly paper. And one can appreciate that it looks slightly like that. Um, I just want to go see if I can start that again. Um, yeah, so ridges, obviously some of the other um, classical features are edema, we've got rings. You could even argue that there is what's called trachealization here, although probably not your most classical picture in this patient. Um, exudates is something we don't see on this page, and then obviously things that you furrow, yeah, furrows as well. And then obviously the one thing that you don't want to see is strictures, which isn't here, but those are what you want to avoid. And obviously there's a sort of protocol for treatment, PPI, elimination diet, and some of your biologics that are used. But you would discuss those options with your patient. So I think just I think this case kind of highlights, although there are abnormalities, I think a lot of people, if you're not looking for it, might miss that, and that's why biopsies are so important when investigating um, dysphagia in a normal appearing esophagus as well. Alrighty, so is this the next one or is it the same one? Sorry, I'm getting, I don't know if my slides are moving very nicely, sorry. Okay, here we go. So this is another case of EOE, and this is far more dramatic. So one can see these sort of almost ulcerated lesions on the side with these rims or ridges that are almost undermined, and one can appreciate these ulcers down into the mucosa. Um, and this is, I mean, I must say, this is not a typical presentation. It's not one that I've personally seen. but just to show the spectrum of disease that can occur with EOE. Um,
Can I say one or two things
Alrighty.
about EOE, quick, Simon?
Mm, yeah,
I'm a surgeon, so I tend to not treat these patients because I try to send them on to the gastroenterologist. But we have to have a very low threshold to think about EOE. So any patient with dysphagia, if you scope them and the esophagus looks normal, please biopsy them. Take some distal biopsies and something more proximal. And the pathologist is looking for 15 eosinophils per high-powered
yeah,
field. Um, I think maybe it's more prevalent than we think, and we're just not looking for it. Maybe that's why we're getting better at it. This is a very extreme case here with these ulcers. This was one of the cases we had here a few years ago. I haven't seen that again, but it obviously causes stricturing. And the other thing that's from a manometric point of view, so I do esophageal motility, and on manometry, if you have active EOE, you can often have quite strange looking manometric changes, sometimes incredibly weird. It can look like achalasia, it can look like EGJ outflow obstruction, it can do all sorts of things. And the underlying question is, well, how does it do that? Because most people think this is a purely mucosal inflammatory disease, but it's actually transmural, so it affects the muscles as well. So it can cause quite significant dysphagia and it can fool you. You can think maybe you're dealing with achalasia, but actually you are dealing with EOE. So it's very important for us to biopsy it. And ideally, you want to do that with the patient off a PPI, like you want to do if you're looking for reflux, if you can do that. So ideally, do the first scope off a PPI, take your biopsies, and if you get 15 eosinophils or more, then you've got your diagnosis.
yeah. And I think just to add to that, I think the importance of doing those biopsies in two different sites, so that mid esophagus or proximal esophagus biopsies are going to help differentiate um, that eosinophilia caused by GORD down distally from EOE as well. So there's two different sites are very important as well. Alrighty. So the next case is probably something that we've all seen. So this was an HIV positive patient with a CD4 of 2. And I think everyone can appreciate I think there's probably an element of debris, but this looks like at least esophageal candidiasis. And then as we go down to the mid esophagus, one can see this punched out ulcer, um, very clear borders. And this was most likely, there's a nodule there as well, but this is most likely CMV esophagitis. And here it's important to take biopsies not only from the edges like we usually taught, but also from the center, as your yield for CMV is much higher from the center of the ulcer. Alrighty, so I think this is where we're going to get onto some of the motility cases. And yeah, fortunately we have Matt with us to guide us through them. So the first case we have is a 35-year-old lady who presented with what she described as terrible heartburn, chest pain. She also reported some dysphagia, and the scope showed some esophagitis, small hiatus hernia, but otherwise it was a relatively unremarkable upper endoscopy. This was her swallow. So one can appreciate maybe that, I mean, it doesn't look overtly dilated, the esophagus. One can appreciate that maybe there's some tortuosity in that sort of mid to distal section, and maybe a little bit of holdup. But it's not the most sort of um, classic, swallow, I don't think. Um, I don't know if you want to see it again. When we look at when we look at the esophagus vertebrae as the vertebral bodies as a reference, 50% of the vertebral body as a guide. So if the esophageal diameter is wider than that, then we're concerned that there's dilatation, and it's probably borderline. I don't know if you'd agree, Matt.
Yes, I think probably some of those look slightly dilated, but it's not, yeah,
Yeah.
it's not obvious. So it's easy
So
to,
yeah, so I think one of the reasons this patient was referred, I think, was that they were considering a Nissen application.
yes.
And so the treating team was very diligent and did an HRM prior to that, as every case being referred for a Nissen should have prior to that, because the last thing you want to do is miss an achalasia. And fortunately, um, this is what was picked up. So one can see that the first thing one looks at, I'm going to bring up the Chicago 4 classification shortly, but the first thing one looks at is the IRP, the um, integral, the integrated resting pressure of the um, esophageal gastric junction. And it obviously depends on what system you're using. But on this system, the upper limit of normal is 18, and we can see that the IRP, I'm just trying to see, can you see, you can't see my mouse, obviously, eh?
Yeah, we can.
Can you? Okay,
Yeah.
so the IRP is 22, so that's obviously elevated. And we can see this column across um, the esophagus of what would you call pan-esophageal pressurization. So everything that is outlined in black is more than 30 millimeters of mercury, which is the cutoff we use for pressurization. And the other thing one can see is shortening of the esophagus here. So this is all classic features of um, type 2 achalasia. So fortunately, she didn't go for a Nissens, but ultimately underwent a laparoscopic Heller's myotomy with an anterior partial fundoplication, which would have been the best thing for her. Um, yeah.
Simon, I've just
All
got
right.
there's two little comments in the chat. I just want to
That,
address
yeah,
them. So
cool.
there, somebody's asking, do we see the case summaries, the slides? So we didn't really have case summaries for the first few cases. So I think that answers it. We'll show you more case summaries now. How long should a patient be off PPI before EOE assessment? You want to answer that, Simon?
So, I mean, I think there's variant, but some people say 4 weeks, but I think at least 2 weeks should probably suffice.
Yeah,
But a
I
lot of
agree.
people say
At
four.
least 2 weeks. Yeah.
Yeah, a lot of guidelines I think say 4 weeks.
Now back to this case, I just want to highlight. So this patient was actually referred in for a Nissen because the symptoms sounded so much like reflux. And this is the strange thing because the dysphagia actually wasn't that prominent in her case. But if you ask carefully, much of her heartburn was actually chest pain. It wasn't heartburn. It was the pain of distension from it. Again, it can be indistinguishable. So this is why it's so important. Um, and I know manometry is not available everywhere, but this is the problem when you don't have it available, is you might miss this. Because in early achalasia, the scope can be normal, can look quite normal, and the barium swallow can look reasonably normal, unless you have a very high suspicion to look for something subtle. But this is why manometry is so important in these cases.
Mm. So I just thought, so this is the Chicago 4 classification, and this is what we use to help evaluate patients with suspected motility disorders. And essentially, it's these disorders are broken up into disorders of esophageal gastric junction outflow and disorders of peristalsis. And as I pointed out in the first case, your first sort of branching point is your IRP. And if that's elevated or abnormal, and then looks at what the peristaltic pattern is. And if there's absent peristalsis, then that's generally when we are concerned for achalasia. And obviously there's the different types, type 1, type 2, and type 3. And that depends on what's the sort of predominant feature. So completely failed peristalsis would be your type 1 achalasia. Type 2, which is what we've just seen, is where there's panesophageal pressurization in more than 20% of the swallows. And then in type 3, you have premature contractions, and yeah, and failed peristalsis. And there may be an element of panesophageal pressurization as well. With regards to your disorders of peristalsis, so you have a normal IRP in these cases generally. I'm sure there are some subtle things and nuances that Matt might know about, but in general, one then looks at, again, your sort of peristaltic pattern, and depending on whether there's failed peristalsis, whether there's premature contractions, hypercontractility, or ineffective or failed swallows, you're going to then classify your disorders of peristalsis accordingly. And so, yeah, so this is a useful slide to know and to, yeah, um, to learn, I guess.
Yeah.
Alrighty, so I think I'll
Just go back to Simon. Maybe I can just comment.
mm,
So Chicago 4 is what's being used worldwide. Chicago 5 is going to come out at some point. They have started working on it. I'm not sure what changes we'll have, but for now we're working with this. I think this table really, I mean, it's a long document, the Chicago 4, if any of you have read it. But it basically is the document we use to decide what diagnosis to come up with based on the manometry. That's what it's there for. It's not perfect, and many patients don't fit a specific manometric diagnosis. They don't fit a specific thing. So sometimes it can get quite challenging. We're in a very lucky position here where we can discuss cases with international experts on webinars, people who've helped write Chicago 4, for example, and sometimes they also debate and come up with things. So like anything in medicine, it's not perfect. But this is kind of the framework we use, and it's nice to have a patient that fits one of these. Doesn't always mean we can manage them specifically, but it is nice for them to fit into these things. And basically, the first thing is always to look at the IRP, which is the integrated relaxation pressure, and that's an average, a median over at least 10 swallows. So it's not just one swallow. That's important to remember. And based on that, we then go left or right on this sort of flow diagram. The ones on the right, which are disorders of peristalsis, are in order of they outrank each other. So absent contractility outranks distal esophageal spasm, that outranks hypercontractile esophagus, etc. So if you have a distal esophageal spasm and a hypercontractile esophagus on your manometry, we call it a distal esophageal spasm because it outranks the hypercontractile esophagus, just to put that into perspective. But that's a little nuance. I don't think one needs to discuss that in too much detail. Thanks, Simon.
cool, thanks. So the second case is a 79-year-old lady. She is known with scleroderma. She's had long-standing symptoms of chest pain and dysphagia every day for 5 years and is now getting worse. She denies regurgitation or any loss of weight. She's been on PPIs, but they haven't helped at all. In fact, she states they've given her diarrhea. And she's also known with hypothyroidism. She doesn't use any opioids, which is always an important part of your history, is to find out what medications they are, as they can influence your manometry, particularly opioids. She's a non-smoker and is still very active. She swims 2 to 3 times a week. She doesn't have a G-scope done prior to this, and this is her swallow. So here you can immediately see that this is a dilated esophagus. There's a column of contrast that remains well into well into the study. This should have disappeared down into the stomach in a normal patient. One can appreciate that there is a sort of almost bird's beaking appearance, and I think for all intents and purposes, this looks like achalasia. Sorry. Alrighty. So she went on to have high resolution manometry, and Matt's kind of pointed out some of the details. So but maybe just to add that often, so well, manometry is generally done in a supine position with water swallows, and then subsequently done. There's some provocative tests that one does. So this is the initial study. So in the supine position, drinking water, and we can see that her IRP is 10, which is not does not meet criteria for achalasia. However, she then went on to do we went on to do some provocative testing with multiple rapid swallows. So this, if I'm not mistaken, tests your peristaltic reserve. And one can see here that the IRP has shot up to 26. So that's above normal. But throughout, there's no peristalsis whatsoever. So there's no activity here in the esophageal lumen at all. So again, in upright water swallows, the IRP is elevated. And then one does the rapid drink challenge, and here the IRP is just above normal. One might argue that there's a little bit of shortening of the esophagus. So with regards to her report then, so her in the supine position, there was completely a peristaltis, but her IRP was normal. So that would make the criteria for absent contractility, so a disorder of peristalsis. However, when one did provocative testing, she met criteria for type 1 achalasia. Now, these are her endoscopic pictures, and we'll go into this a little bit more detail, but one can see that there's pooling of saliva. She has a massively dilated esophagus. And when we come distally towards the OGJ, one can see that there's esophagitis. There's a small, tight esophageal gastric junction. Here, the esophagitis is more prominent. And when it does open up, one can gets the feeling of a very edematous, sort of thickened OGJ. Now, I was discussing this with Matt a bit earlier, but I think this he was pointing out that at the end, this patient ended up having just quite a severe esophagitis on the background of probably a sort of pseudoachalasia or from scleroderma, and that this edematous OGJ actually was causing a degree of outlet obstruction and giving that elevated IRP. So she ultimately wasn't really a true achalasia type 1, but yeah, quite an interesting case. And yeah.
Yeah. Simon,
I
maybe
think what, yeah,
so I think one of the points, I mean, this was quite an unusual case, but I think we all need to know something about scleroderma. You will come across these patients, and in systemic sclerosis, the esophagus is often involved. They can also get gastric involvement and get a gastroparesis, which can make things even more tricky. And you basically get a stiff esophagus. So they get absent peristalsis, but the IRP is usually low. The LOS does open, and they actually also get quite bad reflux because they get physiological reflux that goes up into this esophagus that basically can't empty itself. So they get pathological reflux, but there's no LOS problem. You don't want to go and wrap this patient because the problem is actually lack of drainage. So if you go and wrap them, do a Nissen, you can make things a lot worse, even though they've got pathological reflux in terms of esophagitis on scope. So they're very tricky to manage. I think this case highlights that sometimes you need all three of these investigations to come up with a diagnosis. The barium swallow looked like achalasia, although if you look carefully on some of those images, the LOS opens actually reasonably well, but there's a dilated esophagus that doesn't empty. The manometry showed the classic findings in scleroderma, which is absent contractility with a low LOS relaxation pressure. But then the scope actually kind of gave us the final verdict, and what we landed up with here was actually just severe edema from a very bad esophagitis, and she was treated with PPIs and her swallowing improved. We can't make a peristalsis better. She shouldn't get a myotomy. That's also not going to help her here because she's already got reflux problems. You're going to make that worse. So in this case, very tricky, but in the end, PPIs is what helped this patient. So I think just a difficult case, but it highlights how we must put the whole picture together and use our brains to come up with an idea. We can't just go on one test and then say that that's the be all and end all.
Yeah. So third case, the 61-year-old lady who was concerned for reflux and was referred for a 24-hour pH study. So her symptoms were heartburn with regurgitation and a chest heaviness. She had reported some symptomatic improvement to PPIs, but to only some brands of PPI, and but also reported dysphagia, but only occasionally. She also reported painful shoulders, right upper quadrant pain, and bloating. And her past medical history was quite extensive. She had Crohn's disease with multiple previous perianal surgeries and small bowel resections. She had chronic diarrhea and was taking daily loperamide and codeine PRN. And besides that, wasn't really on any other medical treatment for her Crohn's disease. She was hypothyroid. She had hypothyroidism, although was euthyroid at the time of testing. She was on fluoxetine for depression. She was obese. She'd had a recent squamous cell carcinoma on her left hand, which had required resection and a graft. And she was an ex-smoker, but was vaping. And gallstones were documented on her ultrasound, which was probably accounting for her right upper quadrant pain. And she was under the care of her HPB with regards to that. Her endoscopy was reported as normal, and the question then was whether she'd had non-erosive reflux disease, and she was sent to MAT for manometry to rule that out. So this was her swallow. And so, yeah, so one can see that this is probably quite a normal swallow. The esophagus seems to be of normal caliber, and there's no real hold up. Um, yeah, I mean, there's not a lot that would that you would. Yeah, the swallow hasn't really given us much information here, or other than that, it looks relatively normal. So she went on to have manometry done, and I think this just highlights the importance of not just relying on one test. And so her manometry here, again, we start off with IRP, which was elevated, and in this case, the distal latency, which is the DL, was 4.3 seconds. So normal should be more than 4.5 seconds, and that essentially measures the time taken from the I think the initiation of swallow to is it the opening of the OGJ?
Where the peristalsis starts slowing
This,
down.
yeah. So that should be that should be more than 4.5 seconds. And so what we see here is a very quick or rapid distal latency, which is and with that IOP, and you can see the number of swallows are very similar, high IOPs, the distal latency all less than 4.5, and this is sort of indicative of maybe a type 3 achalasia. This IRP was normal, but there were elements of panesophageal pressurization here. You can see the outlined green column here and potentially here as well. Here the IRP is very high, but the distal latency is a little bit longer. And then the cookie swallow, which is another provocative test as well, revealed an even shorter distal latency and higher IOP.
That go back to that picture, Simon, because that's kind of the textbook picture of what a type 3 achalasia looks like.
Achalasia looks like.
Yeah.
Yeah.
So it's very short,
Um,
premature peristalsis. So this is spasm. And if you have two of your 10 swallows that look like this, plus the rest don't have normal peristalsis, which none of hers have, you meet the criteria for type 3 achalasia.
yeah. Um, and this kind of summarizes that. So, um, yeah, high IRPs, with premature contractions in more than 20% of the swallows in both supine and with the upright cookies. However, I think she was on opioids as well, and so that
Yeah, so
may have that may have
this case was interesting because she was taking so much loperamide, and
yeah.
loperamide is an opioid agonist, and not well documented, but is documented that you can get exactly this picture from opioids. And actually, this is what we think she has. So we don't rush to go and do a poem on this patient, per oral endoscopic martomy, or even Botox her, but rather try and get her off all those opioids. It's difficult in her because she's had multiple Crohn's problems and she's got very debilitating diarrhea. So to get her off the loperamide and to get her off the codeine is quite tricky. But this has been the plan. Yeah.
Alrighty. So our fourth case is a 71-year-old lady. She's a retired nursing sister. She's had long-standing dysphagia, which is now progressively getting worse. It's predominantly to solids, particularly bread and apples. And occasionally she needs to purge to get relief of that feeling. She has dysphagia and regurgitation every day, with occasional chest pain. Um, she's got no loss of weight, and there's been absolutely no response to PPIs. She's hypertensive on several antihypertensives. Um, Importantly, no opioids, and she's had no history of anti-reflux surgery. Um, she had an upper endoscopy performed um, in private, which showed a diverticulum at 25 centimeters and with a Z line at 30 centimeters, dilated esophagus, and esophageal gastrojunction, which opens with pressure, but there's no stricture, and then a large hiatus hernia. So this was her swallow. So one can appreciate that sort of distally these outpouchings, in keeping with probably the documented diverticulum. But there's also this sort of tortuosity, one could argue maybe corkscrew type appearance, um, as well. Distally, with a little bit of hold up of contrast probably in the distal esophagus.
And a large hernia.
And a large hernia. Yeah,
See,
so that's
all that
important as
gastric
well.
tissue is pushing up above the diaphragm, and it's got a very short, squished up esophagus. Maybe we can go through the manometry quite quickly, Simon, because I think we're going to run out of
Yeah.
time.
Yeah, sure. So importantly, yeah, so the manometry was done. Unfortunately, the because of the hernia, which is always tricky, the catheter didn't pass the diaphragm, but it did pass the swallow. So it makes readings a little bit more difficult to interpret. But one can see that IRP here is normal is zero, which is unusual, but probably because it didn't cross the diaphragm.
Yeah, it's not reliable.
DCI, yeah, which is the distal contractile integral, should be more than 450, I think it is, and
Hmm.
between that and 8,000. And you can see, so that's this would be classified as a weak um, contractile, yeah, weak peristaltic contraction. This is a multiple rapid swallows. Um,
So basically,
IRPST, I think
she's basically got very limited reserve, and
reserve,
I think the criteria for an ineffective esophageal motility IEM was met
yeah. Um,
until we gave her
but
stuff to eat, and then
as we, yeah,
yeah.
one can see, yeah, if one just looks at the DCI over here, one can see that as the more cookies she's eating, the higher that gets. So it's up to 3,500, which is still normal, but now it goes over 8,000. And the IRP is slowly increasing as well, which obviously, as we've said, might not be reliable. But the DCI now up to 13,000 and now 22,000. So she has basically hypercontractile um, and hypercontractile esophagus.
Yeah, and I mean, this is another very tricky case where the discussion was, well, what are we dealing with here? Is this an underlying primary esophageal dysmotility? There's clearly a problem because she's making little diverticuli, and and or is this related to the big hernia? So if you've squished up the esophagus, is it not just struggling to empty itself? So that's very difficult to know. And we've actually opted to, she's still waiting for it. She's going to get a paraesophageal hernia repair, straighten that esophagus, everything down, and then we'll see what his symptoms are like. We can always repeat the manometry, and hopefully this time I can get all the way down. It'll be interesting to see.
Yeah, so that just summarizes that. And was actually presented to some overseas specialists, as Matt has mentioned, we're fortunately able to do, who sort of both agreed that IRP was probably not that reliable. Yeah. But one of them felt that maybe it might meet criteria for type 3 achalasia. But I think, as Matt has mentioned, the plan is to first correct the paraesophageal hernia. So this is our last case, and very nice sort of endoscopic appearance. So here we are in the stomach, coming back, coming up the esophagus. There's the Z line, up, and as we insufflate here, we see sort of double lumen appearance, and a big diverticulum with food content inside. Sorry, just waiting for that done. Yeah. Hi. Sorry. And this is the swallow, and one can see how much contrast is retained in there. So just briefly, essentially, there's two types of uh, sort of causes or broad causes of diverticulum, and they're classified into traction and pulsion. Traction usually is a result of external pathology pulling on the esophagus, and pulsion where there's increased pressure pushing out, very, very briefly. And so when one sees this type of thing, one needs to think about an underlying motility issue as a cause for a pulsion diverticulum, especially in the absence of any sort of disease, pulmonary or nodal mediastinal disease or pathology. And so manometry here is important to perform. And one can see here that this patient has a normal IRP, so we're now into the realms of the peristaltic disorders, but her DCI is 23,000, so she has a hypercontractile esophagus, which has probably resulted in that diverticulum. All right, and management here would probably be surgical, I'd imagine, if she's a surgical contact with possibly a myotomy, I guess.
Yeah, I mean, the debate in the surgical circles is always whether you should do a myotomy or not, and you are guided by what your manometry shows. But in general, if you've blown out a piece of your esophagus like that, and most diverticuli in the esophagus are pulsion, we're not talking about Zenkas now. Those are actually pharyngeal. They're above the cricopharyngeus. We're talking about esophageal diverticuli. The traction ones are rare. They're usually small. They involve the whole wall of the esophagus, and they're usually at the level of the hilum of the lungs. So they're at the carina level. And they usually get pulled out almost, they always say that the apex or the tip of the diverticulum is above the neck. So things tend to not want to go in there as much. So the patients tend not to actually be symptomatic. They're often asymptomatic, small, and you can leave them alone. The pulsion ones, which are much more common, almost always have an underlying dysmotility. Sometimes it's achalasia. Here it was a hypercontractile esophagus. But if you go and we usually do a diverticulectomy by firing a linear stapler across the neck. But if you don't sort out the high pressure from the underlying dysmotility, you can blow your suture line. If that happens in the first few days post-op, they can get mediastinitis and be very, very sick. So we err on the side of doing a myotomy, and there's lots of things described. Some people do a POEM through involving the diverticulum, so a DPOEM. But the other thing you can do is just do a POEM itself and then sort out the diverticulum later, because sometimes the dysmotility is the main reason they're dysphagic and not so much the diverticulum. Obviously, it's big like this, and food gets stuck in there, they get halitosis, it can bleed, it can perforate, and there's a risk of malignant transformation. So we tend to try and get them off, but they can be very difficult operations to do. Okay, well,
Cool.
Simon,
That's the
thank you
end.
very much. I think because we're at 7 o'clock. Are there any other comments? You can put that on the chat while we wait for comments. Thanks, Simon. That was a really, really great talk. I hope people found it useful. I think dysphagia is such a broad topic, but the best way to actually look at it is to do cases. I don't see any particular questions. Maybe we give it another minute and then we can call it a night. While we wait for questions, I just want to thank Simon as the presenter, and also thanks to Echo from the University of New Mexico and the Echo team, India team, for their support. The recordings of this will be available on the Gastro Foundation website. We say thanks to the Gastro Foundation. The next talk will be on Monday, the 16th of February at 6 o'clock, 1800. And that's going to be on gourd, nerd, and functional heartburn by Dr. Patrick Nachipo, and the chairman is Dr. Ernst Fredericks. Okay. I don't see any other questions, so I'm going to call it a night. So again, thank you very much to everybody and sleep well.
Thanks, Matt.
Bye.